a medical concern that walked in the room. So I think she did a really nice job with that.
Mm-hmm.
So great. Eye contact. What's another one?
Her body language was like close. She didn't sit far away, like she didn't care about the person. She seemed, you know, caring.
Okay, so she, to piggyback off of that, Tom, she scooted her chair up next to her patient. So there's that, you know, that space, you know. My 6-year-old calls it the bubble room. That's how they do it in school, you know. This is my bubble space so that you don't become too invasive in other people. But then there's that just right factor. And it's kind of hard to kind of come up with the right words for that just right space. But I think the student nailed it. You know, close enough where it felt like we're really connected, I really care, I want to help, without feeling that I'm invading your space.
Yeah, because I don't like closeness.
Not many people do. It's really, truly, also the culture you grow up in. Some cultures are very close, you know, they close talk. And then others are, you know, you need to be 6 feet away. In our society, we tend to be, we like that just right space. We are very comfortable with, okay, here's my personal space that you're not invading. But if you're too far away, it comes off as you don't care or there's an issue here. So
too close is not good sometimes.
Right, too close is not so good and too far away. So that is...
I have friends that are...
in your face?
Oh, I can't stand it.
It probably would then go back to the communication skill on the doctors to instantly pick up.
Right, it's a behavior, it's something that they have trained themselves to do. I want to make my patient feel more comfortable, so I'm going to display these certain body language, nonverbal behaviors that help me create that environment.
And then if the patient kind of recoiled back, or some the doctor would know, maybe I'll move my
They
chair.
should be seeing that.
Seeing that and paying attention to the nonverbal communication.
Right. And so that's what we do sometimes with some of our cases. If we have a patient who might be a little kind of off-footed and a little nervous and, you know, keeps to themselves a lot. They don't go to the doctor a whole lot unless it's like an extreme emergency. So the fact that they're sitting in the exam room means that something really bad's going on. And if you pull up a chair right next to them, they might be like, whoa, this is uncomfortable. I don't like this. Already as a patient, I feel put off. I feel like uncomfortable. I just don't like it. And so the student has to read that body language from the patient. What is my patient most comfortable with? Because remember, communication's dialogue, right? And what is dialogue?
Back and forth.
Back and forth. So as much as the student needs to be focused on knowing what's proper and what's the best communication skills and techniques and body language, nonverbal behaviors to use, they have to be good at reading their patients as well. So somebody that's sitting like this ought to tell them something different than the person who's sitting like this with their arm on the chair. So they need to come in, and that's the first thing that they should be doing, is observing. Before they even say hello, taking that 5 seconds to use their senses, sight, hear, smell, obviously they're not tasting anything, but to come in and say, what do I see going on in this room? And if I see a patient sitting there cowered in the corner, they should know nonverbal behavior of that patient's telling me something, and I need to respond to it. So, nonverbals, keep going with those, a few of those. So we have great eye contact. She had nice body language, posture, keeping the appropriate distance, but showing concern for the patient. What else might she have done, well or not?
Well, she took notes often.
Okay.
But there was one part that I noticed she didn't, towards the end, when the patient had said, did I tell you about the tingle on your feet? She said, no.
Right.
But she had.
Right.
So she had.
Right.
And she had taken lots of notes, like between her eye contact, yeah, she was.
So that's funny that you picked up on that.
Yeah, because I said she did it twice, right? She did in the middle and towards the end, correct?
So where that came from, that's actually kind of interesting. You picked it up on. The SP couldn't remember
I wondered
if
about that.
the student had asked or not, because you figure this is the 8th time she's did this case that day,
Oh, my.
within that 4-hour block.
Oh, brother.
So she's like, oh my
It does get
gosh,
hard to
am I
remember.
thinking that it was the last student or did this one? So she said, did I tell you? And what did the student say?
She said no.
No.
But did she?
Yes.
Really?
Yeah.
Yes, she
Yeah.
did.
Yes, she did.
So the student missed that.
Yeah.
So the student must have been somewhere else. In her notes, in her thought process, she didn't hear that. So,
And that's when she started to seem a little bit rattled.
Yes.
yes.
Yeah,
That-
She might
at
have
that
caught
point,
it.
maybe the time, I kind of contributed that, possibly the time, like you said.
Yeah.
She became aware of what was going on for her time constraints. She just realized that she didn't pick up on a big, big issue. And that could tell her a lot of information about what's going on. Because at that point, she didn't really examine the, tingling and she wasn't there. Nothing was telling her to go there because she missed it. She didn't hear it. Hearing is part of
Yeah, the
communication. You need
In all
to
that
listen.
writing, she should have written that down right off the bat.
Yes.
I think,
She was doing quite a bit of note taking. We don't know what she was writing down because I don't have those notes.
Yeah.
But I think her note taking was appropriate. I don't think it was distracting. I don't think it took away from the rapport that she
No.
was trying to build with her patient. So I think her level of note taking was appropriate. But what she was writing, we don't know. So it's apparent she missed something.
She's like, I'm nervous.
Maybe,
I'm nervous.
right, yeah, I have no idea what's wrong with this person. And maybe it was buried in her notes, because she did take quite a few. And maybe when she was looking over it, oh my gosh, there it is, I did write it. But she wasn't in it. She wasn't mentally in the case.
Right.
She was worried about getting down the documentation. Because that would have been a big light bulb that should have gone off. And if she heard it and really listened and heard, the difference that they say, I know you
Yeah.
hear me, but are you listening? That may have been going on right there. There's a lot going on in their minds.
and it also might have been, in my notes, she was describing the pain around her middle, and her skin felt funny, and her feet were on pins and needles. But it kind of went away on its own, and she went right into her grandmother being in a wheelchair. So I wasn't sure if the doctor got.
Made that connection or the
Well,
link?
it's just that the patient talked fast, also, and it might have got blended in there, and could have possibly missed it. Or,
So here's a technique that students should be using for communication skills. If they're not sure, what should they be doing? Ask again, right? I'm not quite sure I got all of that information down. Would you mind repeating the last part of that? Or here's what I have in my summary. Remember, we always talk, and Sarah, this will make a little more sense to you a little bit later, but we always want them to summarize, right? Summarize what you heard. That way the student and the patient are on the same page. It gives them an opportunity to recapture what's going on, make sure that they did hear everything correctly, and to make any necessary adjustments at that point.
and also, when she went on to about her grandmother, she also told the doctor that she believes it was because it was, or she thinks it was because of a nervous condition. And I'm sure that cued the doctor into a bigger picture.
Right, so she got sidetracked with
The
hearing
real-
about this grandmother, maybe sidetrack's not the greatest term, but it shifted her focus.
Yes.
And almost like, okay, everything I just heard might not be as important as I thought it was. So maybe she didn't write it down at that point.
Because
You never know.
obviously tingling, the way the girl described it, something was going on.
Right,
More
absolutely.
than just carpal tunnel.
Right. So,
Should she have asked about other members of the family with similar things, or if she had children and were they affected by, or had any of these things?
So
'Cause those were
remember,
never any questions.
when we have our cases are broken down into segments, right?
Right.
So we have the history of the present illness, we have their
Family.
past medical history, we have their family history, their social history, and actually children fall under the social history because they're not part of the patient's past. They can't inherit anything from their kids. So in that, she should have picked up on that in the family history, but if I remember correctly, I think the patient gave that information before she went to family history, if I'm remembering correctly. So,
I can't remember
I
now. I just put down that I thought that she
She said she was never pregnant, but or
She-
that
yeah,
she
the
was
doctor-
not pregnant at the
yeah.
time.
Right.
Not
So-
pregnant.
That would be something we could go back and look at on the
Mhm.
video, is how did she gather that information. But think of it from a patient's perspective. So you guys have a unique experience where you know what they should be asking. As standardized patients, you know the format, or you will know when Sarah gets more trained. You know the format. You know they need to ask about my history of my present illness. So what brings you in today? Then they go through the whole rigmarole to gather their information. Patients, lay people, they don't necessarily know that, right? So they think, I'm sitting back as your patient, thinking you're asking me all the questions you need to know. So a patient, a lay person, who doesn't have this insight that you guys do, would simply just go and answer the questions they're asked and not provide necessarily any additional information. That's the risk that physicians run by not asking the right questions. You got to get the information you want, you have to ask, because people aren't necessarily just going to provide you with information. That's why communication skills are so important, because in building rapport with your patient, because the better rapport you have, the better questions you have, the more information you're going to get as a physician to come up with a better differential diagnosis. So if I just come in and I have numbness and tingling and I never ask any questions, I go, okay, I think you probably have diabetes or some neuro thing going on, and what else could cause numbness and tingling in my medical brain here? Okay, it could be this, this, and this. Okay, have a nice day. Here's a script, or here's a follow-up test I want you to do. That's why we bother going through all those questions.
Mhm.
They tell us the patient's story. You don't get the story unless you ask. But also, you don't get the story unless you build a relationship with your patient, right?
Mm-hmm.
And I'm sure we all have great experiences in life with physicians, and maybe not so great experiences where, you felt like you're coming in getting drilled, that you should be, in boot camp, getting drilled with questions. So what's this? And there's never dialogue. It's all closed-ended, yes, no questions. We are training our students to ask open-ended questions, get the big picture, and then appropriately use your closed-ended questions to clarify and to help guide you. So that is a part of a communication skill, is knowing how to ask these questions along with maintaining a relationship. So it is a very tricky place that these students are in, because they have all this medical information stored up that they're trying to hear what you're saying, to use that medical knowledge to help figure out what's going on. But then they also have this whole patient relationship piece that they have to manage as well. That is solely based on relationship building and building a rapport and conveying trust. And it's not an innate trait that a lot of people have, but it's a good thing. The good thing is that you can learn communication skills. You don't have to be born this great communicator. You can ask. And that's what we're going to get to in just a few moments, is the actual measurement tool that we use that is new to the university, called the Calgary-Cambridge Guide. So that is our framework, communication skills framework, that our students are learning on. I might not be the world's best, communicator. Maybe I'm very introverted, or maybe I'm shy. But I have this framework in front of me that will guide me through an encounter and help me learn how to have great communication skills and build a relationship when it might not be something that I necessarily think I'm great at, or don't have that knack. So, what I think we're going to do is talk a little bit about her actual verbal, and we'll come back, and the nonverbal skills will still probably pop into our conversation as we go.
When are we doing this?
Right now. So we are going to think about some of the words that we said, and Jackie already kind of hinted on that earlier on in the beginning about how she said okay a lot. So that's definitely a verbal, a verbal communication that she was doing that may or may not have made that patient feel comfortable. We all interpret things differently, And actually, after speaking with that patient, what she had told me was that that was her reassurance, that the student was hearing her. So some of us took that as, we felt maybe she wasn't listening, going, okay, 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 after everything the patient said, but that's not how the patient interpreted it. So it's a very tricky place. That's why from an observation point, it's difficult because you're not that patient. However, what I'm training you all to do is to know that there's various types of communication, and that student should be mirroring your behaviors and should be looking to see what's the best way to interact with this patient. It might be completely different than the patient I just saw. So we tell our students they wear many different hats, right? So, you know, some patients are more, I want straight to the point, I don't want fluff. Some people say, okay, I need a little bit of fluff, I need a little bit of, you know, human touch to this, I need some communication that might not just be about what's wrong with me. I need to feel cared for. Some people say, well, I feel cared for when they get down and dirty to the business, tell me what's going on and how we're going to fix it. Some people say, well, I need to feel a little nurturing, little, okay, I'm here with you as a patient, doctor, but also maybe as, you know, somebody you can lean on kind of thing. So everybody's different. There's no right or wrong. There's individuals, that's the goal of the student, is how do I treat everybody differently but still get what I need as a physician to make the right decisions. So, and going back, that's what that Calgary-Cambridge guide is going to help us with. And it's going to help them. Again, it's a framework. And they may have gotten this far with never having any sort of framework. Some people are just good at it naturally, right? They're just good people skills. They know how to work a crowd. They know how to work a person. They, you know, make friends easily. They can influence people regularly. And we've got some people who take a step back, who like to listen, not so much be the spotlight. So, got to work with it. And this is the good thing about the Calgary-Cambridge guide, is it teaches them that you can do that. So,
But why would a doctor be wanting the spotlight?
well, it's a shared
examining
spotlight.
a patient.
Right, it's that
I don't get
one-on-one.
that.
Some people just don't like, you know, they don't like that one-on-one. People focusing in on listening to what they're saying and having all eyes on them kind of thing. So really, the spotlight's on the patient. I mean, the patient's there. The patient comes
Yeah.
first. But some people are very uncomfortable with being that voice, right? Of here's what's going on, and it's all eyes on them. And it's very intimidating for some people, especially when they're on the other side of the bed. You know, they're used to being a patient, but now they're in med school and they're standing, and they're that person who it's, I'm the patient, I'm focused on solely on what you're saying, and I've got to help you right. So that's very unnerving for a lot of people, and it just makes people rattle in their pants sometimes. You know, that's we can see it on video. You know, and especially comparing first year video to third year, and you can see the students' growth in their communication skills. They look back and go, I can't believe I was such a nervous wreck talking to somebody, because they've grown so much. And they said, but that's how I was my whole life until now. Now I know how to work with people and build relationship, because it wasn't something I was strong at. And then you got people who could look at this and go, oh yeah, I do all that already. And just go right in and have a great experience with their patients. So.
And then it's a whole personal preference thing too. Some people like a certain kind of a manner, and some people are totally thrown off by that same manner.
Absolutely.
So it's,
That's probably why they change doctors, or there's lots
Yeah.
of kinds of doctors out there.
Right, because you want a good fit.
You have to fit, and sometimes we don't always fit with the
Right.
doctor that you think you might fit with.
Right. And it may not mean that that physician
It's-
doesn't know what they're doing.
Mhm.
It's just that fit wasn't there.
yeah.
That's right.
So these students are worried about building a patient base, and you know, and I'm going to get out there in the world, and nobody's going to want to be my patient because I have horrible bedside manner. And that's what's going on in their minds as a first-year student coming in, bombing their first, you know, patient encounter. And then we introduce them to this and say, don't worry, we'll get you through this. Here's a framework that will assist you in building those communication skills.